So now let's move and discuss how is it that ventricular pressure and ventricular volume interact with each other. In the cardiac cycle lecture, we looked at what happens to ventricular pressure with time and what happens to ventricular volume with time. Remember the main graph of that lecture was on top what's happening to the ventricular pressure or aortic pressure with time as time goes on. And at the bottom is what's happening to the LV volume, how the LV fills and empties as time goes on. Now, if we forget time as a variable, and we simply plot, we look at the left ventricle, we're going to use the left ventricle as an example, and we plot what is happening in the left ventricle, pressure versus volume, and we just take time out of the equation. There is no time. What happens is this. You will have this figure where on the x-axis you have the volume of the left ventricle, and on the y-axis you have the pressure in the left ventricle. And this is exactly the same cardiac cycle we discussed in the previous lecture, but we're looking at it in a slightly different way in what we call the pressure-volume loop. So if we start at the bottom of the graph at the left side in point A. Point A is exactly where we started when we discussed the cardiac cycle, which was the very end of systole when the ventricle is empty, the end of the isovolumic relaxation, right at the point where the mitral valve opens. And this is where we're going to start now. So if you notice at point A, the left ventricular volume is at its minimum. In this example, it's 50, right, on the x-axis. And the LV pressure is to a minimum because that's when the LV has relaxed enough to a point where it has gone right below the mitral valve and the mitral valve opens. So what happens what did we say is phase one of the cardiac cycle? What happens when the mitral valve opens, where you have blood gushing into the left ventricle and rapid filling? So you move from point A to point B rapidly, and blood fills the ventricle and the volume in the ventricle is increasing. And then from point B to point C, you start filling the ventricle even more, and until you reach the full LV and diastolic volume. Now notice, as you move from point A to point C, you have more than doubled the volume of the left ventricle. You have moved, in this example, from 50 to 120 mLs of blood. That's a lot of blood, with almost no change in pressure. So the left ventricle has relaxed, and it has enough of a capacity and enough of a compliance to fill itself all the way with 120 mLs, which is the end diastolic volume, with pretty much a tiny increase in pressure, if any. And this is a reflection of the compliance of the left ventricle. Now, at point C, what happens? The LV starts contracting. This is the start of systole. As the LV contracts, the mitral valve closes immediately, and the LV pressure starts increasing in an isovolumic way. Therefore, there is no change in volume whatsoever because this is isovolumic. The aortic valve has not opened yet. And from point C to point D, therefore, is the isovolumic contraction. Total common sense. Until the left ventricular pressure reaches the aortic pressure, which is, remember, the aorta is now is at the very end of its own diastole. So this is point D would be the aortic diastolic pressure, which in this example happens to be 80 millimeters of mercury, which is normal. And it reaches that point and the aortic valve opens. Now, the point at which the aortic valve opens is the start of the ejection phase, and therefore the pressure keeps increasing because the LV pressure has still not reached its peak yet, but it has opened the aortic valve, and it starts pushing blood out. Therefore, the volume in the left ventricle starts decreasing. Now, you notice you're moving backwards on the x-axis because now volume, as you move from point D to point E, the volume in the left ventricle has decreased from 120 to roughly 70 or 80 mLs of blood. The LV reaches its peak systolic pressure at point E, which is exactly the systolic pressure in the aorta, which in this example is 130 millimeters of mercury. And then the LV starts relaxing. So the LV pressure has reached this peak and it's now decreasing, decreasing, decreasing until it steeply starts decreasing and drops below the aortic pressure at point F, which is where the aortic valve closes. And from point F to point A again is the steep, fast drop in pressure, which is the isovolumic relaxation, all the way from point F to point A until at point A, which in this example happens to be at 8-9 millimeters of mercury, the LV pressure drops below the left atrial pressure. So in this example, you can deduce that the left atrial pressure is around 8 or 9 because that's the point at which the mitral valve opens. So really you can get a lot of information just from looking at this graph, and it's pure logic, pure common sense. So whatever you're asked about a pressure volume loop, you can deduce just from looking at the graph. Another important thing about pressure volume loops is, remember, time is not part of this loop. Therefore, the amount of time it takes the ventricle to move from one point to the next is not proportional to the length of that segment, meaning from F to A, this whole green segment is a split second, is a very brief, it's a very brief time, which is the isovolumic relaxation. From C to D, also the isovolumic contraction is very brief. So if you look at this graph, from B to C is, as a length I'm talking, is roughly equal to CD. However, from B to C takes way longer. Diastole takes long, the heart is relaxed. And from C to D is very brief. So remember, as we move around this pressure volume loop, different segments take different amounts of time because time is not part of this graph. Now, if we go back to the bottom part of this pressure volume loop, which was the point from A to B and then from B to C, this is when the left ventricle is filling with blood. This is diastole, and exactly like the previous lecture, from A to B, this part corresponds to the early rapid filling of the left ventricle. When the ventricular pressure is still dropping from A to B, you'll notice that pressure still drops a bit because the LV is actively relaxing. And when the LV relaxes, relaxation, which is an active process, creates a suction effect, creates a negative pressure effect. And therefore you have a further drop, slight drop in pressure from A to B. And then from B to C, the LV now is in its full relaxed state. And from B to C, the left ventricle is filling passively, and at the end of it, from the left atrial contraction, which is not part of this graph, it's just the very end of the segment from B to C, is this final few cc's of blood that fill the ventricle. Therefore, the more compliant the ventricle, the more it should fill with volume, with very little, if any, pressure increase. And therefore, this is a reflection of LV compliance, and compliance is simply delta V over delta P. How much volume can you fill with as little a pressure increase as possible? This is a measure of LV compliance. So if we relook again at segment A to B and B to C, this part, BC, the slope of this part, is a reflection of the compliance of the LV, passive compliance of the left ventricle. So by the time the LV has fully relaxed and has reached point B, the active relaxation process is over. Now the ventricle is just sitting there waiting for blood, and blood is coming to it from the left atrium. So from B to C, this segment is a reflection of how compliant the LV is as a chamber. The connective tissues, the myocytes, etc. The LV as a chamber, how compliant is it? How much can it accommodate? Volume. Therefore, if I show you this line and I tell you the pressure volume loop has moved from the original segment BC, purple, to this segment BC in red. And I asked you, what is abnormal here? Well, what is abnormal here is, for whatever reason, this ventricle is sick and less compliant. And in order to accommodate the same amount of blood, which is 120 mLs, it's accommodating them at a much higher pressure, meaning the end diastolic pressure, instead of the LV end diastolic pressure being at point C, which is roughly 10 millimeters of mercury, now it's at the end of the red segment I drew for you, let's call it whatever, C prime, and it's at around 30 millimeters of mercury. Obviously, this is a patient who will be very dyspneic and very short of breath, because an LV end diastolic pressure of 30 means a capillary pressure in the lungs of 30, means this patient is definitely very symptomatic and very sick. Why? Now you're going to ask me why. Why would somebody's left ventricle not be able, be stiff and not be able to accommodate a certain amount of volume? Well, because of certain disease states. You will study later, there are disease states where the ventricle is very hypertrophied, where the ventricle might have more fibrosis, where the ventricle might have the deposition, extrinsic deposition or deposition of different abnormal proteins or components of the connective tissue, which causes it to be stiff. An example, in case you've done your hematology part of your curriculum, you're probably familiar with amyloidosis. So amyloid proteins can deposit in the connective tissue of the left ventricle, and patients with cardiac amyloidosis or cardiac involvement with amyloidosis would have a curve that looks like this, and would have, in order to accommodate the same volume, a much higher LV and diastolic pressure, which is a big problem for them. Now, if I show you this abnormal line, remember, segment A to B, the left ventricle is still actively relaxing. The ventricle hasn't fully reached its diastolic state or its relaxed state. It's still in relaxation, in the process of moving from systole to diastole, and this is an active process. So if somebody right at the point of mitral valve opening has a steep rise in pressure, meaning even if the ventricle fills with 3-4 mLs of blood, it is doing so at a higher pressure, here is a problem of active relaxation of the ventricle, because it's too early yet for the ventricle to reach its full capacity. So from A to B is a segment where, or is a segment where what we're looking at is a reflection of active relaxation. Remember, relaxation is an energy-consuming process, and therefore, if I show you this graph and I ask you what's wrong, the answer is abnormal relaxation. The active relaxation is abnormal. Why might that be? Remember, it's an energy-dependent process. Ischemia might cause this. So coronary disease, etc., lack of blood flow would lead to abnormal relaxation and this amount or this change in the pressure volume loop. So as I said, if you're familiar, if you look at this graph and you understand it logically, you cannot be fooled by any question we ask you. It is just total common sense, like everything else in cardiology, actually. So now, by pure logic, if I show you this graph and I tell you what might be wrong with this patient, so I'll let you think for a few seconds. You notice that what's wrong here is there is no isovolumic phase, meaning the moment the ventricle contracts and the moment the mitral valve closes and pressure is rising, as you see this red segment I drew for you, pressure is rising, but from that very early onset, it's rising, but volume is decreasing, meaning there is no isovolumic phase. The ventricle, from the moment it contracts, is losing blood, is emptying blood somewhere. Where might a ventricle empty blood? Well, there's only two possibilities in this case. Either the mitral valve doesn't close well, that's the most logical, meaning when the mitral valve is supposed to be closed, it's closed, but it's leaking blood backwards to the left atrium, and therefore from the moment of its closure, blood is leaving the ventricle and going backwards to the left atrium, and this would be what a graph of mitral regurgitation. So if I showed you this graph and asked you to give you a series of abnormalities, mitral regurgitation logically would fit with this graph. Where else can the ventricle lose blood? From starting from when it's at a low pressure, if there's a hole between it, the left ventricle, and the right ventricle. Therefore, if this is a baby with a ventricular septal defect, a hole between both ventricles, also the PV loop might look like this. I'm just showing you these examples to illustrate to you how logical, if you think logically, the PV loop will make sense to you no matter what. Moving on, we'll talk a bit about cardiac work now, energy. So as we said, the heart propels a certain stroke volume of blood, and within the stroke volume of blood, there's an energy, a total energy E. And this total energy is used to overcome the resistance to flow of this volume of blood as it moves away and away and away from the heart. Remember what we said, that when we look at energy, there's kinetic energy and there's pressure energy. And how is pressure energy looked at, or how is pressure energy calculated in the cardiovascular system? Well, it's the product of pressure and volume. So therefore, if you want to look at the pressure volume work of the heart, the work consumed by the heart in generating pressure and moving volume, the pressure work of the heart. And we look at diastole as an example. Well, what would be the pressure volume work of the heart? In diastole, it's the product of pressure and ventricle, therefore it's the area under this curve. The area under this curve is simply the mean product of pressure and volume under this curve. So that would be the work, whatever work is left, if you want. So the blood returning to the heart, in diastole has that much left in it. Okay, it's returning to the heart with that much, very low pressure. So what is left in pressure sense in it when it's returning to the heart is the area under this curve. When you read your textbooks, I'm sure you all have physiology textbooks, you will read that this area under the curve is work done during diastole of blood filling the ventricle. This is how it's quoted. I quoted the most textbooks for you, and this can be a little confusing because this is what they quote, work done by the blood. To me, this is the way to understand it's not work done by the blood. All it means is, remember, this volume of blood I'm showing you here, returning to the heart, a few cycles back was ejected by the LV at a much higher pressure. And this volume of blood, in this case, those 70 cc's, because it's 120 minus 50, is a volume of blood which has left the LV, has gone all the way to the tips of your fingers and your brain and whatever, capillaries, veins, back to the right heart, to the lungs, back to the left atrium, and now back to the ventricle. So this volume of blood has left the heart at a pressure of 120 and now returned at this pressure. So whatever pressure energy left in this volume of blood is the area under this curve. And this is what makes more sense. If we look at systolic work, the systolic work, so in systole, systole is from points D to F. And I ask you, what's the total pressure? We're talking pressure, not kinetic. Pressure work consumed by the ventricle, by the LV, and on this particular pressure volume loop, it's the area under this curve. So everything you see shaded in purple is the total systolic work consumed by this ventricle. Now, if I subtract this area from the area of the slide before it, you will get this. So therefore, the net pressure work, the net external pressure work consumed by the ventricle is simply the area of the pressure volume loop. Very simple. Meaning the net work in terms of pressure and moving a certain volume of blood at a certain pressure from the LV outwards to the aorta is simply the area under. It's the area of the pressure volume loop. So if you look at any pressure volume loop and you're asked, what's the pressure volume energy consumed by this ventricle, whatever ventricle that is, it's simply the area of the loop. Very simple. And it's called the net external pressure work. It's not total pressure. Total energy is the net external pressure work. So if I put next to each other an RV and an LV pressure volume loop, roughly, I drew this, so it's rough. Roughly they will look like this, meaning if you look at the x-axis, same stroke volume. However, if you look at the y-axis, much lower pressure, meaning which chamber consumes less, obviously the right ventricle, much less. It consumes a fifth of the LV net pressure work. And this makes sense if you just look at the structure of the right ventricle. It's very thin, less myocytes, and less pressure consumed, and therefore less energy, which is why when you'll later on study ischemia and coronary disease and acute myocardial infarctions, the RV is much less prone than the LV to ischemia. It can tolerate ischemia much more. So if you occlude blood flow to the right ventricle, because it consumes less, it can tolerate it for a while, much longer than the left ventricle. So therefore, one cardiac cycle would consume this net external pressure work. Remember, this one cardiac cycle can occur at varying speeds, and therefore, depending on the speed, can impart a different kinetic energy on that stroke volume. And therefore, this area is the total pressure, net external pressure work. It doesn't include kinetic energy. But if you look at the total energy of one cardiac cycle, the total energy consumed by the ventricle in one cardiac cycle, it would be pressure energy, so pressure volume, meaning the area of the pressure volume loop, plus kinetic energy, the velocity at which the blood leaves the ventricle, half mv squared, plus something called tension heat. Pressure and kinetic energy together are called simply total external work. Pressure work or pressure volume work plus kinetic energy work. It's total external work. Tension heat is energy lost, if you will. It's literally heat. It's dissipated as heat. So the ventricle generates pressure, moves volume, and propels, if you want, a certain stroke volume at a certain velocity. That's all helpful. That's all total external work of the ventricle. But it also dissipates energy in heat. This is energy lost. And that's what tension heat is. Now, what is tension heat? Tension heat is simply energy that is lost in terms of tension. What is tension? Tension is, you studied this, I'm sure, in the vascular part of the course, is pressure times radius divided by a constant 2, but divided by thickness of the LV. So tension is proportional to pressure, proportional to radius, inversely proportional to the thickness of the ventricle at whichever reference point you're using. And tension heat is therefore proportional to tension and proportional to the time in which delta T, that's delta T, the time in which the ventricle is contracting and therefore generating tension heat. So the ventricle generates tension when it's contracting because as we said, when the LV relaxes, the pressure is so low in the ventricle in diastole, in a normal ventricle, with a normal relaxation, with a normal compliance. You saw what is the pressure? It's nothing, 8 millimeters of mercury. There's not hardly any tension in a ventricle that's relaxed. But a ventricle that's in systole, thickening and actively contracting, a lot of tension is generated in this ventricle. So therefore, pressure rises and you have a certain pressure and a certain radius and the thickness of the wall that generates a certain tension, and this is energy which is kind of lost, and this is tension heat. So what is T? T is simply the amount of time in a cardiac cycle or in a minute that the ventricle spends contracting. So T is mostly time that the ventricle spends in systole. Okay, and this is what tension heat is. in order to illustrate to you more in a simpler way what tension heat is. Imagine me, or any one of you, stretching your arm, okay, holding your arm out, and holding your car key in your arm, and you're not moving. You're just holding your car key. You're not moving, therefore there's zero kinetic energy, okay? And if I want to think of this as, do an analogy with the ventricle moving volume forward, you're also not pushing any volume out of the wrist of your hand. And therefore, if I look at kinetic energy, it would be zero. P times volume, because you're not moving any volume, it would be zero. But still, if I remove this key from my hand, from my outstretched arm, which is not moving, and I hold a dumbbell at the gym, a 10-kilo dumbbell, and I'm still not moving, you all will agree with me that in order to hold this dumbbell in a static way and not move for 2 minutes, you're going to consume a lot more energy than holding a key. You're not moving, it's not kinetic, you're not moving volume out of the ventricles, so therefore if you think of PV, it's nothing. It's just energy being consumed and dissipated as heat. And how do you dissipate it? From heat. It's heat going out from your biceps and the muscles of your arms. This is exactly the same. So the example in the PV loop of the ventricle would be the isovolumic contraction. If I look at the isovolumic segment, contraction of the heart, so it was points CD, that segment, if I look at the area under that segment, and the product of PV under that segment is zero because there's no volume change whatsoever. Also, kinetic energy in that segment is zero. Nothing is moving. Nothing is happening, but a lot of tension heat is consumed. This is tension heat. So tension heat does consume energy. It does lead to, of course, ATP breakdown, and it's dissipated as heat. And it's actually the major determinant of the energy expenditure of the ventricle. Most of the energy is dissipated as tension heat. The total external work is only 3% of the total energy needs at rest and can increase to 10% with exercise. All the rest is tension heat. The clinical implications of this can be illustrated in someone with coronary artery disease, for example. So if you're going to have a whole lecture or two on coronary physiology, but when you exercise, you need to increase your cardiac output, and therefore blood flow, coronary blood flow, needs to increase in a commensurate way to keep up with the oxygen demands of the left ventricle. If you have a stenosis in one of the coronaries, so let's say a coronary is 80% stenosed. If you're sitting down doing nothing, this happens all the time. A patient who has an 80% stenosis in his coronary can be sitting watching TV totally feeling nothing. He can even get up, go to the kitchen and come back and feel nothing, because those 20% left in his LAD, for example, are enough to supply blood to the ventricle to do this. However, if this patient goes down to the corniche and wants to walk, he will walk, and around 100, 200 meters after that, his LV, his cardiac output, is trying to increase. However, that segment of his left ventricle is not getting enough blood from the stenosed coronary. Therefore, this patient will start feeling something because of a mismatch between oxygen demand and oxygen supply. And that something he feels would be chest pain called angina. That's called stable angina. Now, we just said that most of the energy consumed by the ventricle is in tension heat. We just said that tension heat is proportional to tension, meaning pressure, radius, thickness, and the amount of time spent in systole, delta T. Well, how would we treat a patient like this, short of going in and fixing the problem? Well, we would treat him with medications to lower tension. How can we lower tension? You cannot affect the radius of his ventricle, nor the thickness of his ventricle. These are fixed, but you can affect pressure. Therefore, what do we give these patients? Medications to vasodilate them and make them walk 100, 200 meters with a lesser increase in their pressure, and therefore less tension, meaning they tolerate this more. And also we give them medications to avoid their heart rate from going faster. So therefore, instead of walking 200 meters and his heart rate reaching, for example, 150 beats per minute, his heart rate will only go up to 100 beats per minute. And if a heart rate only reaches 100 beats per minute, remember, what did we say when we change somebody's heart rate? What duration is changing is diastole, meaning they're spending much more time in diastole if their heart rate is 100 as opposed to 150. So over 1 minute, you have less systolic beats. You have less time spent in systole. That's the delta T part of the tension heat equation in front of you. And therefore, medications are used. The implications of that formula is that you can affect T, tension, by dropping pressure. And by dropping heart rate, you would lower the delta T, the amount of time spent in systole, and therefore less tension heat and lesser symptoms for these patients. That's just an analogy for you to understand that pharmacologically we can affect this. And finally, if we look at all of this, just a definition, what is mechanical efficiency? Mechanical efficiency is simply total external work, pressure work plus kinetic energy work, divided by the total work, total including tension heat. And that's just a definition that this is what mechanical efficiency is. And that has nothing to do with the ejection fraction, remember, don't confuse both. That's just an equation to show the energy efficiency of a certain ventricle. Thank you. This is the end of this lecture, and we'll pick up tomorrow with the next lecture.